Hi, I'm Dr. Howard Jack West, and I'm a medical oncologist with a particular focus on thoracic oncology. I'm an associate clinical professor in the medical oncology division at City of Hope, and I also lead a program called Access Hope that works on remote consult services there. And I'm based in the Los Angeles area. I'm happy to welcome all of you to this multidisciplinary tumor board on a series of provocative lung cancer cases.
Hi, I'm Michelle Ginsburg, and I'm a director of cardiothoracic imaging at Memorial Sloan Kettering Cancer Center. And I'm also vice chair for education in the Department of Radiology, also at Memorial Sloan Kettering. And I'm also a professor of radiology at Weill Cornell Medical College, which is across the street from Sloan Kettering in New York City.
Hi, everyone. I'm Suresh Ramalingam. I'm a professor of hematology and oncology at Emory University and the Winship Cancer Institute. Like Dr. West, my focus is also on thoracic oncology.
Hi, I'm Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of Thoracic Surgery at Emory University in Atlanta, Georgia.
Hi, everybody. My name is Cliff Robinson. I'm a professor of radiation oncology at Washington University in St. Louis, and I am the chief of the Cardiothoracic Radiation Oncology Service and director of clinical trials.
This is a 56-year-old woman with interstitial lung disease associated with scleroderma and also pulmonary hypertension, and has a 2-liter oxygen requirement at baseline, as well as coronary artery disease, smoking history, 35 pack years. And she had an incidentally detected 5.1 centimeter mass at the right lung that was biopsied and is squamous cell carcinoma. We'll have a chance to look at the imaging. The initial clinical staging is T3N0M02B, and we'll talk more. She has a chronic cough and some dyspnea, performance status 1. She also has fatigue. I mentioned her Scleroderma-associated ILD, pulmonary hypertension, pulmonary artery hypertension, coronary artery disease, a prior MI, and a drug-eluting stent. Her smoking history, as noted, she quit in 2019. And the question is essentially, how would we approach this, considering the possibility, if not probability, of a multidisciplinary approach for her? And I'll turn to Dr. Ginsburg on imaging here.
And what we're looking at here is the mass in the right upper lobe, which measures 5.1 centimeters, and that's on the axial CT in the top right. And below, we see that it is very avid on a PET CT with an SUV over 26. On the coronal PET CT, we also see the arrows pointing to this large mass that's very avid. In addition to that, we have multiple slightly enlarged lymph nodes in multiple regions: supraclavicular, para-aortic, pretracheal, subcarinal, both hilar regions. But they were only all mildly avid with an SUV max of 3. And keeping in mind that she does have a history of scleroderma, we should keep in mind that these lymph nodes may just be reactive lymph nodes, not related to her tumor. Also, the difference in SUV may indicate that as well. But obviously, we need histology to prove that. And she did have ultrasound guided core biopsy of both the lung mass and of lymph nodes, and in the supraclavicular region. And the supraclavicular lymph node was negative for metastatic disease.
Okay. So we've gone over much of this. The imaging, as we saw, the ultrasound-guided supraclavicular node biopsy is negative, but the primary is positive for squamous cell carcinoma, IHC consistent with that. Don't have PD-L1, it hasn't been sent, and we can assume that her labs are not a real issue here. But obviously, she has a pretty significant past and current medical history. I'm interested in, Dr. Force, how enthusiastic or concerned would you be? Would you say this person is a a candidate for surgery, or does her significant medical history pretty close to preclude that for you?
So I think it depends. So I wouldn't say just looking at this that she is definitely not a surgical candidate. I think that she's going to be a high risk candidate if she were a candidate. If you break it down, piece by piece. So can we operate and do major lung resections on patients with systemic pulmonary hypertension? The answer is yes. I've done that. We have a fairly busy pulmonary hypertension group here, and every now and then they refer a patient to me. But you've got to team with the pulmonary hypertensive pulmonologist or cardiologist and kind of help them work through the intraoperative and postoperative period. Can we operate on people who have coronary artery disease? Of course, because smoking is the leading cause of coronary artery disease and lung cancer. So most of our patients have stents or have had heart bypass surgery or have cardiac history. Can we operate on patients with interstitial lung disease? Yes, you can. The interesting thing is it depends on where the tumor is. So most interstitial lung diseases, or many, tend to be lower lobe predominant. Unfortunately, her tumor appears to be in the upper lobe. So we'd have to get her pulmonary function test, look at them, and then even potentially do something called a perfusion scan, which shows us how much work each lobe is doing, and try to predict how much of a risk it would be to remove that entire upper lobe. So, if she could walk into my office, meaning, not coming in a wheelchair, then I would evaluate her. She's a young woman, she's 56, so she has that going for her. And I think she would require a workup. And, that would tell me whether I said no, or whether after the conversation, she said no, like it sounds too risky. But just with this information alone, I would say, yeah, she potentially could be a candidate still.
Dr. Robinson, how much of a concern is the scleroderma for radiation safety and feasibility?
Yeah, it's a great question. So, just doing what Dr. Force did, breaking it down, the coronary artery disease and the pulmonary artery hypertension are much less of a concern for us, but the scleroderma-associated interstitial lung disease is a severe risk factor for us. So, in the limited retrospective studies that have been done to date, our primary complication of concern in these patients is high-grade radiation pneumonitis, and ILD quadruples or quintuples that risk. So if you had a 4 to 5% chance at baseline, it's closer to 20-25% in these patients. And fatal events have been described in this patient population. As we've all seen some of these people, sometimes it doesn't take much to push them over. And then when they go over, it's hard to come back. And our usual courses of steroids may not be enough. So I think, that's where multidisciplinary care can be really helpful in this patient, because sometimes the assumption is just that in anybody who's, quote, inoperable or high risk, you send them our way. But this is actually an example of a patient where I would quote our risks as actually being substantial.
The key question is around the local therapy here.
Yeah, Jack, I agree. This is not something that would push us into thinking about systemic therapy at this point. The question would come up if, let's say, Dr. Force says this is not a surgical candidate after evaluation, and it's down to radiotherapy. Would somebody consider giving concomitant chemotherapy? Would come up. And my view is, in a node-negative patient in a peripheral lesion, whether this ends up being an SBRT type of approach or a hypofractionated radiation therapy approach, a concomitant chemo would not serve this patient's interests.
Okay. So overall, for this patient, our thought is that surgery is a consideration, but really needs to be individualized, seeing the patient in the context of the clinic and clarifying their overall performance status, functional status. And also, while radiation could be considered, there really needs to be a lot of individualized care in developing a possible plan for that, given the scleroderma, which does raise the safety concerns.